So let's talk more about resilience. And I apologize that we have cholesterol one more time. And I'm going to whip through these so we're done. But cholesterol is one of the most important things you can have in your body to fight COVID-19. It's anti-infective. It's involved in repair and recovery. And, it helps the brain. So it's an extremely important thing. So, you folks all know what's going on now. LDL is the common word in the world, the non-medical world for LDL and HDL is a someone say soap. Thank you, Amy. Gold star, and plus all the stuff you send me, which is great. So, if you can't get cholesterol to the brain will make some, but, it's expecting the liver to make some too. And so if the liver's not making it, you're probably going to be in a deficit, and you're going to get a brain that's not properly wired. I mean, the reason why the omega-3, omega-6 ratio is important, we need more omega-6, but you're literally transmitting the electricity in the brain across the outer membrane. And if you don't want a semiconductor in your brain, you want a conductor. And so the omega-6s are not a good conductor for what the brain has to do. So your wiring gets all screwed up. I said I'm going to be quick. So here's a good article from Psychology Today, where they basically said the importance of cholesterol in the brain relative to cholesterol and the heart health has been mostly ignored. But I would say they've gamed the heart health data, obviously, from the Nature study and all those other studies. So really, you really can't. This is an incongruency that cannot possibly exist considering how vascular the brain is, 10 times more vascular than normal tissue. So well-intentioned and putting us in the right direction, but not strictly correct. The study that really was the landmark one for me came out in 1998, where they studied in British prisons fish oil group and a non-fish oil group and followed them, and showed just by charting out behavior that the fish oil group of prisoners had much less antisocial behavior and, more importantly, prospectively less recidivism. So it just shows you how important fish oils are to downregulating inflammation. And keep in mind, everything is redox. Our body's electrical, something electrical, even though it may be miswired in my case between my brain and my mouth, it's electrical. Moving my arms, it's electrical. Everything's electrical. So, so what happens is the fish oil is involved in redox, just like a vitamin E, an antioxidant. It's a beneficial substance. When something gets oxidized, the fish oil molecule, which is very sensitive, comes along and spares that thing that's been oxidized by giving it an electron and becoming oxidized itself. That's how it works in an anti-inflammatory way. Everything to the base is chemistry. And if there's any physicists out there, chemistry is more important from a practical perspective. So we talked about this gentleman last time. Oh no, this is a different group. Cholesterol myth. We'll skip that. We'll keep moving on. So this is the study that UCLA used to decide that our cholesterol standards, our LDL standards and total cholesterol standards aren't low enough because such a large number of people were coming into the hospitals with cardiac events, and it was up to 75% with normal LDL values. So what their conclusion is they weren't too low, is they weren't low enough. But of course, the data on the J curve is very clear. The lower you go, the much more dramatic bad outcomes of all types are. So not a good interpretation. The Daily Mail report suggests that statins are more likely to cause calcium in the arteries. Statins block the production of vitamin K, which stops calcification. So lovely interlude, musical interlude. But I have my own music for the video, by the way. But, Um, 12 million people in the UK are taking statin drugs. Well, they should have no heart disease then. And then we talked about heart failure already. I mean, basically, it's a muscle. CoQ10 is regulated. You need CoQ10 for the activity of your vessel. So here's another study on artery calcification. Based on statins, the coronary artery calcification increased by 9%, whereas the placebo group plaque volume increased by 5%. So simvastatin, one of the big statins, Electrostore, I think, does not reduce progression, and of course they wanted to, calcification. So I always say, does not reduce. Shouldn't it say increases progression? So that's, trying to put lipstick on the pig. Let's keep going. So this is the one I referred to a while ago, the Zocor study, which is the industry's best landmark study to prove that statin drugs are effective. And they are effective in a narrow cohort, and the average age was around 55. It was a bell curve, so most of the people in the study were 50 to 60, men, already severe cardiovascular disease. And so what they showed, and I won't go over the math here, but basically they had 182 deaths in the Zocor group, 256 deaths in the placebo group. But it was out of 24,000 patient years. So they go 182 to 256, that's 28%. But really from an absolute perspective, the thing that really determines whether you're going to do well or not, you're certainly not getting a 28% benefit, is 3%. But on a yearly basis, it's only a 0.65% reduction in risk, 0.65. But that's just for heart outcomes. Total outcomes, neutral at best. It's hard to find those studies, but most studies show that, and we've already looked at Proto from Harvard and all these other things that say statins seem to be missing the one key ingredient that's most important, longer life. So it's very clear that we may reduce some cardiovascular deaths because of the antibiotic nature of these drugs, but overall, not so good. On with the show. So it's a 30% association. It's really important to understand the difference between association and causation. So association will be sort of the relative statistics, where causation is really the absolute statistics that we're worried about. And there's almost no paper. I've told this story before, but I'll tell it again to honor Dr. Trump. Every year, being a subscriber to the New England Journal of Medicine since 1968, they would ask Dr. Trump and other longtime subscribers, what can they do to improve the quality of the New England Journal of Medicine, the top medical journal in the world? And he always just wrote back one thing: do not publish relative statistics. Only publish absolute statistics, which translated into medical terminology is numbers to treat. And we're going to talk about numbers to treat hopefully very soon in this session. I'm just trying to see. So here's David Diamond and Uffe Ravenscoff, who belongs to the Thinks group that I belong to, and Dr. Carter belonged to as well. It's International Society of Statin Skeptics. But Diamond is a cardiologist. Ravenscoff is a medical scientist. Kimmer McCulley's on that, my good friend up at Harvard, pathologist at Harvard for 50 years. So when you look at things so when you talk about the statistics, when you look at things from an absolute perspective, there's your benefit. The difference between the red and the blue in terms of what the benefit could be. And this is published. So, I think they're a little bit off here in terms of the new data since 2003, that we're really not seeing a mortality decrease, probably seeing a mortality increase. Remember that statin slide I showed you, the one slide on statins where I compare the smoking rates to the statin intervention and the cardiovascular death rates actually went up right after statins were introduced. So, but it's just, the point is when you graph it out appropriately from an absolute perspective, you really have to get a magnifying glass to see the effect. And this is always just really measuring heart disease. So let's look at some different cholesterol-lowering drugs, not just the statin drugs, or LDL-lowering drugs, not just the statin drugs. Look at some of these things. So, okay, well, I'm still on the statins. Unexpected antimicrobial effect of statins. Okay. So it's significant antimicrobial activity against MSSA. I don't even know what it is, but some sort of infectious disease. But here's from my book, Quarterback Your Own Health. And this was from 2012. So studies of antibacterial effect of statins. My favorite one, unexpected antimicrobial effect of statins. So plenty of publications. There's probably several dozen now. Probably not published in JAMA or the New England Journal of Medicine, but they're in other journals. Patients with periodontitis have increased LDL and triglyceride levels. We talked about that a little bit. So when you have, that's the UCSF, University of California, San Francisco studies. When you have inflammation or infection, LDL goes up. Why? Because the infection is creating damage. And the cholesterol molecule transported through LDL is part of membrane restoration and repair. So, of course, it's going to go up. It should not be a surprise. Here's our science hero. Statins have antibiotic effects against chlamydia pneumonia. So that's, that may be at the root cause of their antibiotic activity that saves your vessels, because as Tom Brody said when we interviewed him, he took antibiotics, don't anybody get scared, but he took antibiotics for 3 years. This is the guy who developed the triple antibiotic therapy for H. pylori, part of the Nobel Prize team for H. pylori and stomach ulcers. And he had brilliant guys involved in the Open Biome Project in the United States. I hope he didn't coin the term crapsule, but his name's associated with it. But he said, I had chlamydia pneumonia, it's hard to get rid of. I treated myself for 3 years. And then his joining comment was, because my heart's important to me. And that's what this organism does. So, and like I said, people at Pfizer, people at Warner Lambert that I know told me they know their antibiotics. So here's Ravenscough again, showing that high cholesterol may protect against infections, not the statin drugs now, the cholesterol molecule itself. So you're putting a mattress under water when you're dealing with the LDL lowering drugs, because they have some antibiotic activity, or at least the statins do. But the cholesterol molecule does too. So that's why you're not seeing a tremendous improvement in mortality, because you're giving up one for the other. And so you're breaking even at best, not considering the other side effects. So here's my book. And if anybody needs a PDF copy, let me know. And then if you do take a PDF copy, you must send me edits, because it hasn't been copy edited very well. So here's a different statin, a different cholesterol, LDL lowering drug. See, when you see this word, it's the kiss of death. Results from clinical studies are inconsistent. That means it doesn't work. Has little or no effect on clinical fatal endpoints. No significant mortality benefit was found. And what kind of drug is this, Dr. Carter?
What type of drug is what?
Ezetimibe, Ezetimibe.
Ezetimibe.
It's probably a biologic of some type.
Yeah, probably. I'm not familiar with that one.
Yeah, good for you. You know, we don't need to know this stuff. But see, niacin. A lot of functional docs give niacin, and I just had someone who was getting 3 grams yesterday or some dang thing, or Friday, and it's just like, it lowers LDL too. So, I mean, we all need some B vitamin, but at some point, what is its action? Why are you taking such a high dose of something? So this is from the New England Journal of Medicine from about 20 years ago. And I love the Brits. Maybe he's not a Brit, but it feels like it. But when they're doing high-dose niacin, 3 shaky pillars, the clinical results were chillingly null in terms of improving heart outcomes. Niacin did not reduce the incidence of primary composite endpoints or any clinical benefit overall in the major subgroup of heart disease. Trial was stopped early by Independent Data and Safety Monitoring Board because the boundary for futility had been crossed and an unexpectedly high number of ischemic strokes was observed. So once again, if you don't have LDL, you don't have cholesterol, but all these other important inflammatory reducing healthy substances and anti-infectives, vitamin A, vitamin D, the cholesterol itself, all the different oils. So, you know, you're just losing the battle between repair and recovery and wear and tear. And the vessels are going to be a very strong indicator of that. And of course, this was published quite a while ago, 20 years ago. And I have doctors, when I show them this article from last year from Neurology about stroke, they tell me that the data isn't strong enough. Yet we already see from niacin the same effect of lowering LDL and a preponderance of ischemic strokes. But that was ischemic in that case. I think these are hemorrhagic. So we're seeing an increase in both mechanisms of stroke. And here it might be due to more calcification, whereas this is vessel deterioration. And I can assure you that both processes are going on. So here's more nice fuzzy thing on more stroke risk. Not a good deal. So looking at other LDL lowering drugs other than statin drugs for a moment here. So what we do when we do that is we look at their mechanisms. Statin drugs affecting liver, liver enzymes, so we're not producing CoQ10, we're not producing K2, or no, we're not producing LDL, but there's several other things we're not producing. I think it's K2, but my memory's foggy on that. But we're not antimicrobial. But the common mechanism among these other drugs with the statin drugs is LDL lowering. So let's see what we see when we have drugs that isolate just the LDL without these pleiotropic effects that the statin drugs have. So looking at these other drugs, looking at cholesterol trials and mortality for the other drugs, experience with early drugs such as blah, 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 lowering cholesterol as a biomarker did not automatically translate into patient benefit. Once again, a very nice language by telling your son that their girlfriend is pleasant. It means keep looking. Or vice versa, or your daughter's boyfriend is pleasant. Probably wouldn't use that term for the boy. Let's not get political. Disappointment hits as Amgen's Repatha prevents heart attacks but not deaths. Lie. Okay. Now, one of my best friends is a cardiologist, and I remember distinctly, I was in Knoxville at this mountain bike park, and it's raining, so I haven't hit the trail yet. And Craig calls me. And I don't know how we got on this topic. And I said, Craig, those biologics for LDL, they're really bad drugs. He says, what do you mean? They're amazing drugs. So there's two people with very different perspectives. Are they amazing? Yes. What's the endpoint? Lowering LDL. Are they not amazing? Different endpoint. Mortality? Not so good. So if you are really a fanatic about lowering your LDL, these are amazing drugs. But when you look at the disingenuousness of what they say, I'll get to that in a second, I guess. But these PCSK9 inhibitors is the popular media says these drugs haven't caught on because they're too expensive. Okay, but why have all the other expensive biologics caught on? The ones for arthritis and so on and so forth, and every biologic is catching on. So what makes this particular biologic not catching on because of expense? Humira, very expensive, all these drugs. And I think the reason is because the clinicians know that they're killing the patients. So therefore, they're not ordering them. That's my hunch. So here we go. Don't know that I believe this is Repatha. Increase the risk for all-cause mortality. And if it's being published, the doctors are seeing this. With statin drugs, you don't see a huge increase in mortality. You don't see an increase in heart events. You might see a slight decrease in some, an increase in others, but they're out the door. Not your problem anymore. But so that's the problem. So here's a QALY. In America, we do not have a QALY per se. But in the national health countries, England in particular, but others, they're trying to look at the value of a very expensive drug to have a decent outcome. So they have a quality adjusted life years. So they look at the cost and they look at improvement in health and longevity. Quality adjusted life year or quality adjusted life, okay, well, we have it twice. It's a generic measure of disease burden, including both the quality and quantity of life lived. It is used in economic evaluation to assess the value of medical intervention. One QALY equates to 1 year in perfect health. The Swiss Medical Board reported that cost per quality adjusted life years, QALY, could be extremely unfavorable for statin drugs. In England, the break-even point for a drug to be approved, the QALY is $20,000. So the statins are grandfathered in, no surprise. But if nobody knew about a statin and they hadn't made $1, and they did the studies, and they did the QALY study on it, and it came out to 225,000. Oh, we need another zero. Pardon me. 225,000 for the statin. Rather than 12 million people in England being on a statin drug, it'd be zero. Zero. Because it would not pass the economic and health benefit criteria by a factor of 10. Okay, 10.25. Okay. So in the final report, SMB recommended that statins should be used in primary prevention only if the risk score is at least 75% over 10 years. So they're folding a little bit and saying we're stuck with these damn things. So how can we get them to the fewest people as possible? Because with the quality of that, it really is saying this is a highly, highly ineffective drug. Okay. Of course, England is in bed with the FDA, so they're not going to go there. But they should if they don't want to go broke. But, that's their problem. So bones, you need, we all know this, you need K2, you need other cofactors to replenish your bones. And if you're lowering your LDL, you're lowering the availability of these cofactors. Was greater than 3 times as common in people on statin drugs. Okay. Let's see. So more on statins and joint pain. We'll keep going so we come to a terminus on this, but I know everybody's probably pretty tired. Some guy keeps sending me these articles from the New York Times Well blog, and this came out this year. Statins tied to risk of skin infection. So we see once again that when you suppress your immunity, which it's really doing by lowering LDL, and its ability to bring those fat-soluble nutrients around, that you're more susceptible to all types of infections. So not just HIV, which really was the landmark study that articulated the need for high levels of total cholesterol. People below 160 were dying like flies when they had AIDS, whereas the people above that were doing much better. So here's skin infections. You know, effect on sperm count, but now we know why. Cholesterol is a precursor molecule to prohormones like vitamin D and hormones, testosterone. So, yeah, I would say it would have that effect. So, you know, there's been a lot of, as you can imagine, for COVID-19, there have been a lot of studies saying, hey, these drugs seem to work pretty well. No question, no kidding. You know, dozens of articles that say these drugs work pretty well and should be considered for use. And the main reason why they do that is because they don't want the people coming off the statin drugs. So they're trying to reassure, just like they're reassuring in COVID on the biologics, which immune suppress. And it's extremely difficult to comb through the literature and find a genuine article that says those drugs don't impact COVID. In fact, I found one that, you know, I'll have to go back to one of my COVID slide decks that showed very clearly a huge increase in bad COVID outcomes this was from the Rheumatoid Arthritis Society on those drugs. So, you know, it's very challenging when the industry is so strong. So their argument is like, there are 100 articles to your one. But they tried to publish 200 and 199 were rejected. So and that's what's going on out there. So you can see that we see a big increase in critical illness, 31% from 20%. And I would say that would be a 20, 30, 10 is a 35% increase from a relative perspective, but from a absolute statistic, I don't know exactly what it is. Just to be, you got to be fair on both sides of the equation. You know, I mentioned a long time ago that on the drug label, they present the harm in absolute statistics. So it's a small number, 2%, like Lucentis for eyes, you know, it's anti-VEGF. It stops your ability to create new vessels, which you may need when you have a blockage. And so there's very, very high mortality, 2 to 4%. Would you take a drug that would increase your chance of dying from a heart attack by 2 to 4%? You know, but see, we've been so conditioned to the benefit. You improving letters of vision, you know, which isn't even a real, why aren't they talking 2020, 2040? They created a whole new scale because it's such a minor benefit. And for that, you get a 2 to 4% increase in early death from a heart event. But they'll always talk about the benefit in relative and the harm in absolute. I know this gets confusing, but we'll do some label reading at some point to show you in some study reading so you can see what it's all about. And I'm going to republish that blog on absolute versus relative statistics shortly. So if you have a traumatic event, who would have thunk this? If you're a bad healer, you may bleed out or you may be in the hospital longer, and nobody wants that. So that's how important getting cholesterol to damaged tissue is. It's part of your repair and recovery mechanism. So I used to say, you're not a bad healer, you just have poor repair and recovery. Well, maybe it's the same. Maybe it's the same thing, said in a different way. But you know, we can now understand why you would be in that state and where your LDL levels are and how they may fluctuate with events will be a very important marker indeed. stopping statins may benefit terminally ill patients, but of course we don't want to do that because it's costing society too much money. You know, statin withdrawal produced a significantly improved quality of life and a non-significant increase in survival and reduction of symptoms. But, you know, that's important. I mean, you know, these are really sick people, so they're on death's door anyway, unless you have some dramatic interventions. But just to like allow your heart to work properly, allow your body to repair tissue. Of course, that's going to, how about the wounds on your bum when you're sitting in a hospital bed and you can't move? This is, you know, getting off that drug will most likely help that as well. Autoimmune diseases, lots of data on that. Case report, 76-year-old woman, and she has all these different patients on simvastatin daily for several years. So on and so forth. We won't dive into autoimmunity, but it's just, you know, I think what the point is, it's not about autoimmune disease or cancer or heart disease or skin infections. It's the fact that this molecule, cholesterol, is highly involved in general immunity. And, you know, I wrote a book on this, which Dr. Carter and I are working on updating and improving because we need to make it more focused on COVID because it's really the driving force. But in this book, we talk about, you know, the chronic inflammation, hidden infections, but we talk about tertiary immunity. And believe me, it's not just about white blood cells and antibodies, and it's not just about a couple of things we talk about here, but the things we talk about here are very important. Cholesterol is part of the tertiary immunity, no question. The other piece of that we talk about here are amyloid, so they're plaques. Once again, plaques are there as part of the innate immune response, and that's Dr. Moyer and Tansey at Harvard. The amyloid of the brain in Alzheimer's is an antimicrobial peptide. It's there to protect you. So why are we, you know, I'm not smarter than those people. Why are they building drugs to lower these two basic immune supporting things? You know, Pfizer and company spent billions trying to reduce the amyloid burden by directly targeting its production. No, it's part of the immune response. It's like trying to suppress your white blood cells, which chemotherapy does, and things like that, and make you more vulnerable. You know, so if you don't get rid of all the cancer and your white blood cells are suppressed, that's why it comes back stronger and harder, and you're more likely to die. Your immune system's been suppressed. It takes a while for it to recover. But doing that to cholesterol, doing that to amyloids, you know they're going to come up with more drugs with these biologics for amyloids. You don't want them. You want the amyloids. You don't want the amyloids, but once you have them, you thank them for the work they do. That's a Lancet, decent journal. And the last slide, you know, are we all old enough to remember Johnny Carson when he was doing Carmack and the Magnificent? And, you know, he had the answer, then he'd pose what the question was. And then when he came to the last one, there'd be this big cheer, but he's finally getting to the last one. So his jokes were kind of not funny, but anyway. So if you want to cheer that we've reached the last cholesterol slide, and it's just rhabdomyolysis. I mean, it's just muscle fatigue. So, and I have no concluding remarks. If anybody hasn't watched this gentleman, Thomas Sowell, I have him up here because I've been listening to him at nighttime. He's just a genius, 91 years old. Some other stuff on all-cause mortality. So for older people, looks like I do have a few more. This is from my book. When you're greater than 70, if your cholesterol is less than 160, you have 11 deaths per unit number of people. And when it's greater than 240, you have 4. That's how important it is when you're undergoing immunosenescence have tertiary immunity processes going on in your body. And there's another one on, I know, this actually, we're not done. I got Thomas Sowell out here because he's 91 years old. So this section is older people. So here's Ravenscough again saying that high LDL C, I hate the C, take the C off, it stands for cholesterol, but it's high LDL. It's not a cholesterol molecule. Is associated with, is inversely associated with mortality in people over 60. So when you're over 60, you want high cholesterol. And of course, it's true of all ages, but they at least carved out a niche and got these things published because it wasn't as controversial. Let's see what we have. Aggressive lipid management in very elderly. The findings of these studies suggested in very elderly adults, higher cholesterol levels are associated with better survival. And I'm really annoyed by this because very elderly is 70. I don't know who the heck these people are. A bunch of teenagers doing these studies. This just simply says that LDL greater than 100 reduces your risk of early mortality by 22% if you're 65 or older. Another one where you see a 10-fold increase in relative risk when you have low cholesterol, 131 or below, 10-fold. So there's your J curve. So questioning the benefits of statin therapy in older people without established cardiovascular disease. There are only 2 randomized trials showing an increase in mortality from all causes and primary prevention. Inverse relationship between mortality and LDL. So if you're older and someone's trying to kill you, just say no. So new policy on statin drugs will cause many more healthy young people to take statins for the rest of their lives. Transitioning to the young. And then where is this thing? Beautiful. Pfizer's new Chewable Lipitor. They're not as sophisticated as we thought, Michael. They don't have gummy Lipitor yet.
Wow.
But I'm sure they'll get there. And this is where I end because now it's the European Commission approval of a new chewable form of Lipitor suitable for use in children aged 10 or older with high levels of bad cholesterol and high triglycerides. Yeah, like the statin drug, lower triglycerides, yeah. If you can't transport them, then they may not show up. But this can be nothing short of disturbing. And now the applause may begin because we're no longer talking about the statin drugs. So let me see, my screen didn't do what I expected. Go back here and then stop sharing. I know because this topic is brand new to you, you must have dozens of questions on the statin and the cholesterol lowering drugs, but it's just interesting when you isolate the LDL lowering effect. They're probably a little bit worse, but I think the Rampatha, the biologic is, because the reason why it's so fantastic is the statin drugs lower LDL by 20, 30, 40%, whereas Rampatha can lower it by up to 90%, putting you in a real danger.
I do have a question.
Please.
I do have a question.
Yes.
So the traditional doctors will say that you must keep your cholesterol lower to prevent a heart attack, right? That's the normal guidance. How, if you're allowing your cholesterol to be higher because there are values and benefits to the body, like the brain, what should you check for to ensure that you're not getting deposits of cholesterol around the heart, which is, I'd imagine, where you would not want that to be depositing?
Well, the deposits around the heart would mean that there's an inflammatory process going on around the heart. And so when you look at the way, what's that?
And how would you check that?
Well, the only way you can do it, you can obviously do the calcium score testing, but we're going to look systemically because if it's in the vessels anywhere, therefore in the peripheral blood, you can assume that, it's not a good thing. And I don't care if we're getting rid of it out of the brain or the heart or some other peripheral tissue. But when you look at the way statins work, the effect of all the different mechanisms that allow them to reduce cardiovascular mortality in specific groups is their anti-infective group. So you want to be on an anti-inflammatory, anti-infective protocol. And from my world of looking at these things, looking at elevated CRP, the white blood cell counts, and then looking for organisms like Chlamydia and Pneumonia, which may be present even if your white blood cells are normal. But that's why we do the complete blood count with differential, because we're looking not just at the white blood cell count total, which can be masked because of the balance between lowering lymphocytes and raising neutrophils. We're looking at the neutrophil to lymphocyte ratio, which is probably the most important early barometer, and then looking at the neutrophil percent, and then looking at total neutrophils. So those four things, and then the RDW, the red blood cell distribution. So those things are going to be, they're circulating throughout the entire blood circulatory system. So if we're seeing something focally, then when you put your magnifying glass on, we see things there. But other than scanning, scanning, slight changes in the blood will be an earlier predictor than actually seeing, say, a plaquing. And I think having a total cholesterol of 300 doesn't necessarily mean you're going to have plaquing of cholesterol in that area. It could be just simply doing a repair on tissue, and it may not necessarily be resulting in aggregating. But that's when Dr. Carter now comes in and talks about the particles.
Well, yeah, to expand on that, I mean, also looking at the homocysteine, because greater than 50% of people who have heart attacks actually have a normal cholesterol level, so it's not cholesterol the end all be all that's causing this problem. And obviously a significant number of people who are on statin drugs are still having heart attacks as well. So what I tell my patients is, first of all, we want to look at and normalize all of your inflammatory markers like homocysteine, high sensitivity, C-reactive protein, insulin levels, fibrinogen, ferritin, sed rate, uric acid, all of those, because that's what ultimately drives the process of the LDL becoming problematic. So then you can do a stratification of the LDL, looking at particle size and particle number. So if you have large particles, those tend not to be problematic. But if you have small particles, kind of like little beads, then they will have a greater propensity to embed in the areas where the damage has been done from the inflammatory process, right? Because remember, cholesterol is a healing molecule, among other things, but that's why cholesterol is found, in plaques, because it's trying to heal the damage that's been done from whatever inflammatory process is going on. So doing a deeper dive, looking at particle size, particle number, genetics of the Lp(a) pattern and apolipoprotein B, and from a genetic standpoint, those can be moderated. They don't change a whole lot, but again, if you have those patterns, then you definitely need to be much more vigilant in terms of normalizing your inflammatory markers. Also having ApoE 3, 4, and 4, 4, from generally people may know that as the genetic markers for Alzheimer's that can increase your risk, but they also confer problems with cholesterol levels. So, which, really kind of goes back to everything is not appropriate for everyone. So it really kind of goes back to a personalized medicine type standpoint, because with the popularity of ketogenic diets with, high fat and so forth, and good fats, coconut oil, avocado oil, and so forth. If you're actually ApoE4/4, that is not appropriate for you because you're not mobilizing the particles well, and you will tend to have more small particles. There's also a test that you can do, Oxidized Ldl, which again, that increases the risk for that cholesterol being deposited. So, and then there's Plaque2, which is another great marker in that realm to assess subacute infections, more so actually in the mouth, which will then also affect your, the small particles and the oxidized LDL. So there's a lot of, lot deeper dive that one can do with this. I think I talked earlier, about an individual who I saw with Alzheimer's or early Alzheimer's, and they were actually placed on one of those PCSK9 injectable, like the Repatha, and it quickly lowered her, total cholesterol down to like 140, and the LDL was somewhere around 40. And she, she had significant memory issues, enough to force her to leave her place of work. But the doctor was all excited about those numbers, and they were like, "Oh, this is perfect." And while she had to retire, and of course, I educated her on the dangers of that medication. And 6 months later, her cholesterol normalized, and she was able to go back to work. So, yeah, it's you have to look at all of these things in combination and as a symphony.
Any other questions on this?
Thank you for that. Very useful.
That was good. Those drugs for kids, is that for real? Are they here in this country? I haven't.
Oh, it's been around. They've prescribed cholesterol lowering agents for kids for, I don't know, past 10, 15 years.
Really? I know. That's criminal. That's sick.
Yeah.
Thank God they didn't ask me in the doctor's office with my kids. I probably would have gone crazy.
But again, but those the triglycerides and the LDL and total cholesterol are going up because of the poor diet that the kids are consuming. Right. It's all high fructose corn syrup and genetically modified this and high carbohydrate loads, and yes, it's going to increase, but they're creating the market for themselves.
Right.
All right, all.